Yes. Okay.
Yep.
So that's us recording now, David, and wonderful to see you.
Yeah, you too, John.
We've not seen each other in person for quite some time.
Yes.
And I'm quite excited to be interviewing you. The idea of the Red Talk is that it's a discussion. So I know that we had a talk about this before, but a lot of people will know you in Scotland, certainly. A lot of people might not know you. They'll probably know of your work if they work in the fields of addiction and recovery. And so, David Best, I've known you for quite a long time. You're Professor David Best as well, aren't you?
Yeah,
and you're a normal human being as well.
Reputedly.
So I'm really looking forward to talking to you about this stuff. And the Red Talks Plus is about engaging with people who've got a knowledge of the field, and a lot of experience. And you certainly have. I mean, just from what I know that you've done and things that I've kind of crossed with you over the years, it's been an amazing journey to kind of know you, but also to see the work that you do. And we'll get into that a wee bit. So just maybe tell us how you are today, where you're calling us from, and maybe how you got involved in this side of, in this line of work.
Okay, so where am I just now? I'm sat in a little village called Bamford, which is in the Peak District, which is North Derbyshire. And for people who don't know this part of the world, it's kind of between Sheffield and Manchester. But I'm only 12 miles from Sheffield, but it's just a stunning part of the world. John and I had a talk about this earlier. And this is like one of those hidden treasures in England. So everybody knows about the Lake District, and it's probably 80 miles east. And it's a real kind of walkers, climbers, cyclist delight. It's just a lovely, lovely part of the world. I moved here because my boy and my ex-wife live in Hathersage, which is the next village along from here. And I didn't know this part of the world at all. And I've been here for a few years now, and it's just a stunning place to live. I mean, it's wet. Yeah. It's not necessarily by Scottish standards, but it's wet. And I guess one of the things that's probably worth saying is I've had a fairly kind of nomadic career. I've done an awful lot of traveling, and I've worked in various places across the UK and across the world. So I've been, I've had this incredibly fortunate career, John. And one of the things I think I've been really blessed by is I've been lucky to work with some incredibly talented people. And I've been mentored by a few very generous people, which I have to say in the world of academia is not common because it's nasty and cutthroat and self-interested a lot of the time. But I've been very fortunate. And I've also just been around for a long time. It's one of those things, as you may be aware, John, that you suddenly discover that you're not talking about a 10-year career. And I started doing my PhD with John Booth Davies at Strathclyde about the psychology of addictions in 1992. So it'll be 30 years next year. And I've been in so I was a couple of years with John, working for him and being a PhD student with him. And then I moved into a kind of completely different environment. I moved to the Maudsley Hospital in South London, which was the National Addiction Centre.
Yes,
and it was an incredible place. It was an incredible place to work in terms of treatment services. Because at that time we had 3 inpatient wards. We had a heroin inpatient ward and alcohol, which was 4 weeks duration.
Oh, wow.
We had the same for alcohol, and we had a 12-day emergency admissions ward called the Acute Assessment Unit. And I was based in a massive industrial scale methadone maintenance clinic in Camberwell for about 2 or 3 years. But it was just the most incredible place to be. People think of London as kind of affluent, but our catchment area was really Camberwell, Brixton and Peckham. So there was a lot of poverty, there was a lot of crime, there was pretty much an open dealing network on Cold Harbour Lane in Brixton. So it wasn't without its challenges, and the Maudsley covered the whole of the South Thames area. So our catchment population was 4.5 million. So it's not that far away from saying it's like the size of Scotland.
Yeah.
And that was really a massive kind of testing and training ground for me. Also, as a kind of academic, it really did ground me in the practicalities of running services. And
yes,
a lot of the stuff I did at that time was very, very clinical research. So it was a lot about patient experience, and we would talk about patients at that time because, you know, they were in the hospital, they kind of were patients. And the Maudsley has massive closed psychiatric wards as well. You know, it's not like a community outpatient drug service. But it was a fascinating place to work. But it also rendered me, as you'll be perhaps aware, somewhat cynical about the limitations of specialist addiction treatment. And really, for me, it would probably be in about 2007, 2008, maybe a little bit before, that I started getting engaged and interested in the whole recovery agenda.
So, I mean, your initial training and education was in, is it psychology?
Yeah. So I'm jointly trained. I did a psychology degree at Strathclyde. I did a master's in criminology at London School of Economics. And I did my PhD with John Davis in. And for people who don't know, here's a guy whose work you really should look up if you're interested. And apart from the fact he was an astonishing larger-than-life character, he wrote an incredible book called The Myth of Addiction, which is a kind of social psychology account of addiction. And it's old now, but it's still well worth reading for any. And he really was a kind of inspirational visionary. And he was really the first of the people that I meant that was just an inspiration to work with. So you've moved on from... You moved on from the Maudsley. What happened to your career from there? Oh, okay. So they tried to get rid of me 3 times, John. So first they sent me out in secondment to the Police Complaints Authority for 2 years, which was just fascinating because I didn't do anything to do with complaints. I did deaths involving the police. So I studied police shootings, police pursuits, and deaths in police custody. And then, you know, I'm sure you're aware, they're all incredibly politically hot topics. I think I got back to Maudsley for about a fortnight or so, and they sent me out again to the National Treatment Agency. And you know, so in terms of who I worked for, there's now a name which I think is kind of no longer so well known, called Michael Gossip, who ran a study called NTORS. The National Treatment Outcome Research Study. But my boss was John Strang, who is now Sir John Strang.
Oh, wow.
So he was my boss for most of the time. He obviously had enough of me then. So he sent me out to work for the National Treatment Agency as head of research for them. And for people in Scotland, the National Treatment Agency is like an odd organisation. Well, it doesn't exist anymore, but effectively it was like what's called an arm's length public body. So it was exclusively government funded, and we had effectively a very high level of control over the 149 drug action team areas in England. So they were split into regions, each of which had an NTA regional team. We were based in Elephant and Castle in South London, and it was just fascinating work. It was a very controlled system, very different from Scotland. So it was a centralized system. Effectively, every one of the drug action teams had to provide a plan, a treatment plan for the following year, and it had to be approved by the NTA or it couldn't be implemented. So it was a very centralized control system. And, you know, I'm fascinated to see at the moment, John, there's talk of a new version of the National Treatment Agency being brought back in England. And obviously it brings all kinds of cumbersome challenges and problems of stupid policies and practices. But what it does avoid is postcode lotteries. You know, so at the moment in England, and I feel slightly odd because I can't really talk about Scotland, but in England, you know, there's some great recovery services and systems. Next door to places that are just appalling and have nothing, because it's all so much down to local public health director preferences. So I was there then. Probably the most fascinating 3 months of my entire career. Even the NTA didn't want me then. They seconded me out. So they seconded me out to the Prime Minister's delivery unit, who did these things called priority reviews. So they would do, over the course of 3 months, this was at the time where Blair didn't trust government departments. So he set up 2 units, the Prime Minister's strategy unit and the Prime Minister's delivery unit. And the delivery unit effectively checked up on all of the departments, but were they telling the truth and were they being honest about stuff? Anyway, so I was involved. I was the external advisor on a priority review of drug treatment effectiveness. So it was me, a guy from the Treasury who was doing all the money stuff, and one of these specialist teams from PMDU who would do 4 of these reviews a year. So the team I got assigned to, they'd done mobile phone theft in their previous review. So they had no specialist knowledge. And the way it worked was that you would sit in central London for the first 4 or 5 weeks, gather loads and loads of figures and data, and then you would choose 3 areas in England that you would go out to. And I think it was just England. So ours were West Sussex, possibly not the most representative place, but there'll be less eye rolling when the other 2, Salford and Middlesbrough, which as for anyone who's not familiar with English geography, West Sussex and Middlesbrough might as well exist in different worlds. They have nothing in common. West Sussex is probably the most affluent part of England, but the reason why it was included was rurality.
Yes, yeah, because rural areas traditionally have a challenge that you didn't get in the big cities and stuff where people concentrate.
Yeah, Salford's kind of funny because Salford's like a Manchester overspill in some. Nobody from Salford would accept that. And Middlesbrough is like it's just hard work and it's a grim place. I mean, I was brought up in Motherwell and Wishaw.
Yes.
And Middlesbrough strikes me as very similar.
Yes.
So post-industrial, it had steelworks and it had chemical works, and now it has nothing.
Yes.
Now it has heroin. And it's to be fair, there's now a great recovery service in Middlesbrough called Recovery Connections that do amazing things.
Yes, I've seen that.
It has a really go-ahead commission, but at that time it was a shambles. And really it was one of those things where the kind of conclusion of the report was kind of, it's drug treatment really isn't delivering. At that time the English budget was something like 600 million a year. Through the NTA. And it was just before all that stuff started with Paul Hayes and Mark Easton from the BBC about, so all these people come in the front door of your treatment service and 4% appear to leave. In a BBC Panorama interview, I think it was, which left the chief executive of the NTA floundering ineptly on television, which, really was a crisis point. And in England, in a way that wasn't true for Scotland, the recovery agenda to some extent was provoked by not the success of the mental health recovery movement, but the crisis of parking and methadone, and the suggestion that English treatment was just unambitious, unsuccessful, and going nowhere. So it's that history. So I then moved out of London for the first time in over a decade. I moved to the University of Birmingham and I worked in the Department of Psychiatry there. And I worked partly for the drug action team when I was there. And I liked that. And then basically for academic promotion, I got a reader post at the University of the West of Scotland, based in Hamilton. As a Lanarkshire boy, that was kind of close to home for me, but it was probably too close to home. And I think I'd forgotten just how cold and wet Scotland was. So I only lasted there for a couple of years. And then I got this astonishing opportunity to move to Melbourne.
Australia,
I got offered a job as an associate professor. And again, it was a mixed job because I was based in treatment services. I was based in a big treatment provider called Turning Point. Who are nothing to do with the Scottish Turning Point or the English Turning Point, but they are and were funded by the Victorian Department of Health. So it was set up as a kind of centre of excellence. And I'm not sure everything they did was excellent, but they did a lot of innovation stuff. And it was so I lived in Melbourne for 3.5 years. And it was just fabulous. And, I'll sound like I'm from the Australian Tourist Board. If there's anyone who's not been to Australia, go. The moment they open up, go. It's just an incredible place. So I did some really interesting stuff. I'd been a couple of times. I'd done project work in Queensland before, and I'd visited Melbourne before. But it was just an incredible place. But from my point of view, astonishingly hostile to recovery. I was really surprised. I was involved in setting up the first ever Australian recovery walk in Melbourne, and the level of hostility that it generated. There was a guy whose name I'm not going to mention, who came and took photos to try and out people for going on the recovery walk. It was just an incredible experience. Anyway, so I had some time there. Very sadly, towards the end of the time there, my dad died, and I'm an only child. And I'm not a child at all, but my mother is now kind of pushing towards 90 and lives on her own in Hamilton. So it really did become an issue where I had to come back. I think if it hadn't been for that, I don't think I'd ever have come back. So I came back to Sheffield Hallam. I haven't abandoned Australia completely. So I'd 5 years in Sheffield Hallam, and now I've moved to University of Derby. And I basically spend about 9 to 10 months a year in Derby. And I'm also an honorary professor in the School of Regulation and Global Governance at the Australian National University in Canberra. I go there. And I also have a PhD student in New Zealand based in Odyssey in Auckland. So I go to New Zealand most years as well. So
not a bad life, David.
Not a bad life. And it's no coincidence, John, that I choose to go January and February to Australia and New Zealand.
I'm going to see you over there one of these times, because that's definitely what I want to do. I've got family in the Gold Coast, which was
beautiful,
great to find
beautiful
out.
Temperatures.
Absolutely. So listen, what we've seen there, what I've what the viewers will have seen as well, is the fact that you were embedded in treatment, in early day, but also all the way through, and you've seen the public policy side of things. You've seen stuff, you've done research on stuff that works and what doesn't work. So the next question might seem a bit trivial, but I'm going to ask it anyway. What is your understanding of addiction, to substances? What is your thoughts around that? What's the causes, perhaps?
Well, I think two different questions, John. Causes, I think it's so hard to pin that stuff down, because I think, if you look at the hard science, certainly with alcoholism, there's a very clear genetic thread for it. It would be hard to be Scottish and not have some family, friends, neighbors, whoever, who you see that. And my own family has been beset by, my father was an alcoholic. And so, my family has been beset by those problems. So there's clearly a genetic component. But I think what most people now would see is a kind of epigenetic model, where there's a predisposition that's genetically transmitted, but it really takes a certain set of circumstances, which may well be to do with stresses. I mean, the word trauma, I think, is a little bit overused at times, because I think it's become so common currency that it's almost been rendered meaningless at times. That's not, but in any means, meant to suggest there are not people with serious traumas who inspires addictive behaviors. But I think, it's become such a kind of commonly, widely used word. It's lost a lot of its power and significance. So, there's a genetic risk. There's undoubtedly a maternal deprivation, the kind of Gabor Mate type world about early childhood experiences. That Gabor Mate's work is effectively a reprise of John Bowlby's work from many, many years ago, who I think was another Maudsley person, about maternal deprivation. But those early childhood experiences, and there's no question that some of those things around poverty, poor relationships, poor socialization practices, all of those things kind of create a cumulative tumble. And it's not inevitable, because I think, when you start doing the recovery work, you do see some people, and funnily, I was talking to one of them a week or two ago, where you think, how did you not end up addicted? Because you'd every condition for it. And, sometimes luck, circumstance, resilience, whatever you want to call it, help. So what is addiction? I mean, at one level, there are the desperately unhelpful DSM criteria for dependence, addiction, whatever. And people should be aware, if they're not already, that the field of addiction research and addiction treatment has been plagued by misconceptions and misnomers. So we keep changing the words, but we don't get any more conceptual clarity every time we change the words. So addiction, no longer acceptable. Misuse, no longer acceptable. Dependence, no longer acceptable. So we're now in this funny world of substance misuse disorders, So what does that mean? I'm not entirely sure. So it's just like a bland set of labels. Now, I would recommend people have a look at the DSM criteria,
Yes.
because one of the problems for that is they are so vaguely subjective. They are so many. So I think is it 5 from 7 or 5 from 8? But you know, people, they can be gamed because they generally aren't particularly testable. The second thing is they rely on the mindsets and predispositions of the psychiatrist doing the diagnosis. So they're far from somehow cold, hard calculating science. It seems to me, however, that addiction is likely to involve some combination of craving, withdrawal, and broader life distress. Now, you know, something that John, you know as well as I do, some of our ideas of addictions have been stretched when we move away from substance addictions into behavioral addictions, because some of those things about, well, what do we mean by withdrawals from gambling, or what do we mean by withdrawals from internet addiction or pornography addiction? You know, it makes it feel much more like a family resemblance. And I'm sure you're aware, John, certainly when I was at the Maudsley, our inpatient unit had initially been primarily from our amphetamine users in the 60s and 70s. So out in the leafy suburbs of Beckenham in Kent, we have this fabulous place called the Bethlem, which is where the word Bedlam comes from.
Bedlam, yeah.
So that's the Bethlem Royal Hospital, which is part of the Maudsley. And yeah, so it was originally opiates, and then it switched to being heroin in the mid to late 80s. But then, you know, we started admitting people who were primary crack and cocaine users. And the general issue was we didn't really know what to do with them. What the hell are we doing with you? You're not showing any withdrawals. And then they would leave because they were unhappy. And it was, you know, it was a sudden recognition that a lot of our models of addiction really were based on alcohol and opiates. So it was central nervous system depressants. And I'm not entirely sure we've resolved those things. And I think if you want to go for a very narrow operational definition of addiction, you'll find too many exceptions. Yeah. The other problem, of course, is that we try and isolate it as if the addiction existed on its own, because it's so often, you know, and because I'm interested primarily in recovery, it seems to me this notion of trying to disembody it from broader life issues about families, relationships, mental health, quality of life, all of that stuff just seems like a pointlessly academic exercise.
And yet that's how a lot of treatment is actually pointed towards. It's pointed towards the substance and regulating that in the human body, you know, and that kind of stuff. So that brings us quite neatly on to the next question about recovery. I mean, I met you through that route as the recovery movement was really starting to garner support and energy, and you know, we could rattle off people's names here all day that we know and that we've been kind of assisted by and inspired by and stuff like that. So what is your notion of recovery? Because even that is a contested term. Totally. So what's David's kind of take on this?
Okay, so I mean, for me, I don't want to couple addiction and recovery.
Okay.
It seems to me for that recovery, does it matter whether somebody is or was physically dependent on a drug? No, it's not relevant at all. Are there people who are injecting crack in their groin 3 times a day and are as happy as Larry? Quite possibly. If they do exist, do they need recovery? Absolutely not. If they don't harm themselves and they don't harm other people, I don't care.
Yes.
And one of the things I've always fought hard against is, at least for me, recovery is not a temperance movement. No. Recovery is a movement for people who identify themselves as struggling to overcome problems related to their substance use that's affecting their well-being and quality of life, and or those of them around them. So, you know, for me, recovery is like an aspirational journey that may or may not involve abstinence. For a lot of people, I think the evidence would suggest at least some of the journey should involve abstinence. We don't have to. That's really about well-being, quality of life, and an internal feeling of purpose and meaning. You know, for me, that's, and it quickly stops being anything to do with drugs and alcohol. It becomes just those, to use a dull, cliched phrase, it just becomes one of those everybody's existential challenges about what the hell am I doing and what do I want and how do I get there and how do I behave with dignity and decency to people around me.
Yeah.
And for me, one of the absolutely kind of turning point moments and enlightenment moments was I'd spent far too much time in my career doing, involved in like watching painful prescribing and dispensing processes and detox. And I was invited to, I don't know why I was invited to preside and chair a graduation ceremony for a 12-step program at Lancaster Farms Prison in the northwest of England. So John's nodding like he knows the prison well. And it was a fascinating place. It was also one of the first times I'd ever been inside a prison. But it was for the program, and I guess this must have been quite a big achievement. They had lots of like mothers and partners and whoever were invited in to come and watch the graduation ceremony. And the sheer sense of kind of collective pride and positive emotions was a real road to Damascus moment, because I've been sat in endless, miserable, tedious group meetings at the Maudsley. This was something fundamentally different. And does that mean those folk wouldn't relapse the day they left? I have no idea. But there was something just so incredibly collectively powerful. And for me, the other thing, I think, any definition of recovery can't be all about, because one of the things for me that's different about recovery from treatment is it's not about all stuff that happens in your head or your body. It's something that happens between people as much as something that happens inside people. It's an intrinsically and fundamentally social process that has yielded a social movement. And, and I think one of the really incredible things about recovery is it stops that focus on it's all about what's in your head or what's in your body, because it's not. A lot of it's out there. It's not in here.
Yeah. And that's the fascinating stuff. I know. I think the first time I really heard it kind of put concisely was Johann Hari, when he says, the opposite of addiction isn't abstinence. The opposite of addiction is connection, and that made sense to me. That was for me. I'd been involved in the movement for quite some time, but when I heard that, it was like click, and it was like some things Gabor Mate, some things that you've said, something. It's like these wee pieces kind of come together, and it's like it doesn't matter that you've got lived experience. If you can't express it, then you're limited, and by engaging with this stuff, and that's why I think things like you were involved in the early days of the consortium, which was called something else in those days.
I think had the word drugs in it. I was the first chair of it. Yeah.
I was going to say that you were the chair and stuff like that. And again, there was exciting moments, but I remember in the groups that met to formulate that we got threatened with the civil servant that they would take their money away, if we didn't kind of specifically say it was for drugs. We had
totally.
that in the title, and unknown to them, there was so many people in that group, unknown to them, who were in recovery that I knew, but they were civil servants, they were heads of organisations who weren't out at that time, because it was quite a shaming thing.
Yeah, and don't you think it's one of those fascinating things that has changed but hasn't changed enough? That when I started doing recovery talks in treatment services, I would nearly always get someone kind of sidle up to me at the end and say, I'm really pleased to hear you say this. I've been in recovery for 27 years and none of my colleagues know because I daren't tell them because I'm worried I'll lose my job.
Absolutely.
And you kind of think, now, I think that's much less common now than it was then, but it's not unheard of now.
No.
It still exists, and there's still this kind of bizarre, and for anyone who's not seen The Anonymous People, the film, Greg Williams' film, I think one of the things that's fascinating about watching it is, where do they think it leaves Britain in this context of anonymity or putting your head above the parapet? Because I'm far from sure those battles have been particularly well fought or won.
I don't think they have. I mean, I know the Anonymous People was what, and I think one of the first people interviewed on here was Fiona Gilbertson, who set up Recovering Justice in the northeast of England. And I had told her about this film, before she set it up, she's seen it and she was like, right, I'm going to do something about this. And she did her Churchill scholarship and stuff as well, and it was fascinating that kind of thing ignites in us that what is possible to do as well as drawing that veil, because you've been living inside a system you don't know, because that's all you've ever known. And how do you start to rip that stuff apart and make recovery more visible and aspirational is a good term that you used there as well.
Don't you think the other fascinating thing is, sometimes I get frustrated by the kind of harm reduction versus recovery stuff.
Yes, yeah, that's a pain in the arse.
Which is a pain in the arse, and it still goes on. And, you know, I've been asked to take part in some congressional hearing in Alberta in Canada that's about, you know, I don't know, giving out bottled morphine somewhere, and you think, well, I'm not sure what I've got to say about that. Anyway, but what I was going to say is, it strikes me that a much bigger battle is with the vested interests of treatment services, because I'm a big fan of the Darren McGarvey book, The Poverty Industry. Poverty Safari, sorry. Poverty Safari
it was,
And one of the things that just strikes me is the treatment industry really doesn't, and it applies to addiction academics as well, and I think it especially applies to addiction academics in Scotland. They are too cowardly on the whole to engage in any discussions about recovery, because it doesn't fit the academic orthodoxy in psychology or medicine or wherever. And, you know, this very narrow set of viable questions that can be asked of policy or practice from one of the things that really frustrated me in my 2 or 3 years back in Scotland was the level of academic cowardice about engaging meaningfully and sensibly with the recovery debate. You know, people, it's been a huge frustration for me in every country I've worked in, how academics have cowered away from asking these really important questions about families, about communities, about relationships, about long-term pathways to change, in favor of these, what to me are increasingly stupid and pointless questions about technology, talking therapy technologies and medical technologies, which is, you know, just like different magic dust questions. If I sit with you for an hour once a fortnight and sprinkle magic dust in your head, will your life get better? No, because you have to do it. You know, it's not, and it just that whole model still is what dominates. It's still basically what the addiction treatment industry is trying to do.
So that's really interesting, and I knew you would. I knew you wouldn't need much prompting to kind of speak your mind, David. So that's brilliant. So that's fascinating. I'm sure for people who watch this as well, is you're a great deal of expertise and experience, and I mean, what have you seen in terms of cutting edge practice that you think we need more of this? We definitely need more of this.
You know, one of the reasons why we set up the College of Lived Experience Recovery organizations was I just got frustrated at how little of the incredible innovation that goes on in the recovery world is recorded, evaluated, or published in any kind of meaningful journal. So, you know, I work with just an incredible array of recovery organizations. So when we did the training for the peer recovery research, we did it at the Well in Barrow in Furness. Now, I know if that's any agency, you know, well, downstairs from where we were doing the training, they've got the Well Social Supermarket, where basically, you know, the people who work in the shop are all in recovery, but the people who shop in the shop aren't. The people who shop in the shop are people in Barrow and Furness who can't afford to shop in proper supermarkets. And it's that genuine giving back stuff. You know, it's like I'm just going to cite some random examples. Recovery Connections in Middlesbrough. They go out, they've got a coffee bike, and they go out on the coffee bike, and you get a free cup of coffee if you're willing to have a chat to them about recovery for 10 minutes. You know, and just in terms of recovery outreach, it's fabulous. And one of the NHS services, which I'm so impressed by, and this is somebody I guess you'll probably also know, is Aspire in Doncaster. And Doncaster is another pretty complicated area with lots of problems, socioeconomic problems. Well, the manager of the drug and alcohol's NHS service is openly in recovery and is part of our College of Lived Experience recovery organisations. They have the recovery games every year. COVID notwithstanding, organised by an NHS treatment service for recovery organisations for throughout the UK, and it's just an incredible kind of celebration event for recovery activities, and staff and clients do stuff together, graduates of their service, people from other. It's just fabulous, and you know and in the Isle of Wight, there is now a recovery hotel opened by a guy called John Elford, who's having a conference later this year. And the other thing I think that it seems to be, there's a big debate, as I'm sure you're aware, about the benefits of residential rehab at the moment. And I've been asked to join a Scottish government group, which is a very unusual thing for me to be asked to do now. But I've been asked to join on residential rehab, only because Dave McCartney's chairing it. Otherwise, I wouldn't.
Yeah, that's right.
I've been asked to join that. And one of the things that I just think is fascinating is why we haven't really seen a growth of the Oxford House movement in the UK. You know, there's a guy called Lenny Jason at DePaul University in Chicago who has pretty much devoted his entire career to developing evidence around Oxford houses. And it's just hugely impressive, the evidence base. Now, I know there are Oxford houses in the UK, but they're very few and far between. And our models for treatment to rehabilitation to long-term recovery and recovery housing have been feeble, and it's all because it's partly about these stupid pots of different government money, so they can't be joined up. So I was involved in evaluating jobs, friends and houses in Blackpool. I don't know if have you come across jobs, friends and houses, an astonishing program. So the idea, it took people with addiction problems coming out of prison, trained them up in a building trade, joiner, plasterer, plumber, and they effectively renovated dilapidated properties in Blackpool as a social enterprise. Half of them were sold to fund the social enterprise. The other half were kept as recovery housing for the people who did the building. So effectively, you were building your own house.
Fantastic.
And it was just an astonishing idea. And I'm really pleased to say that it looks like Middlesbrough is just about to develop another jobs, friends and houses. And you know, it's just an incredible. So I evaluated the first year, and we used police national computer data to work out reductions in offending from pre-prison to post-prison. Well, there was a 94.1% reduction in recorded offences for the 50 folk who went through it. Fantastic. And this was a group of people who had, let me get this right, I think they had 238 imprisonments between the 50 of them. You know, so this was not all this low-hanging fruit type business. This was people who had an incredibly complex, generally incredibly complex. And so there are all these, you know, and you go further afield, you look at places like, I don't know, San Patrignano in Italy. There are just, the world is full of incredible recovery innovations and successes, and you know, right down to things like family support programs. And but for me, you know, I've always, like most academics, I'm a shameless thief of other people's models and ideas, and then pass them off as my own, as you know, John. And I've always been, and I was delighted and disappointed to get a message from William White this morning saying, he's basically, you know, he's been doing this phased retirement thing for a long time.
Basically saying, he had retired ages ago, but he keeps popping up and doing stuff.
Well, he's just stopping doing a thing at a time. So he's now stopped doing journal papers. But and you know, another of those people who's just been an incredibly generous, positive influence. But anyway, his generosity's not stopped me from stealing his basic way of working, because you know, he basically regards himself as almost like the chronicler, the historian of the recovery movement.
And he is.
You know, he's a beautiful writer. He's a great thinker, and I've kind of taken it upon myself to be almost like the kind of research equivalent of that for Britain. So I try and make sure I've always got at least one or two research projects that are about trying to highlight some kind of innovation about a recovery service somewhere. And I've been really lucky to partner up with something. And you know, one of the things that I think is really interesting, and it took me a long time to work this out, John, was that, you know, I think when we had big successes, without deliberately wanting to, we tried to kind of McDonaldize them. We thought, oh, this has worked. Let's make it 10 times bigger, or let's create another 3 of them in another part of the country. But it doesn't work like that. No. Because that's not how it works, because it's so caught up with both the physical context, the needs of that community, and the personalities of the people driving the project forward. Yeah. And you know, I really like the idea that what we should be trying to do is to say, how do we create networks of those innovators? Because, you know, if you go back to the 2010 drug strategy, this is a great example of policy stuff, incidentally. I'm going to say this in 2 things. In the 2010 English drug strategy, it talks about developing a cohort of recovery champions. 2010, the speed of policy implementation in England, the first recovery champion was named last year, and it was Dr. Ed Day, a psychiatrist from Birmingham, who himself is not in recovery. Now, Ed's a great guy and a big supporter of the recovery movement, but 10 years later, and it's won. And I've been working on a grant for the last 3 years from the National Institute for Health Research, which was like comparing recovery pathways in Scotland, England, Belgium, and Netherlands. And you know, one of the fascinating things in all 4 of the countries, the question of has recovery policy worked has to be replaced by the question of why did recovery policy never get implemented in any of the 4 countries? And indeed, if you look at the policies, why was there never even a roadmap as to how it could be implemented? It's very hard not to go into a conspiracy model when you read these policies, because you get, like the English one especially, you get Theresa May, who at the time was the Home Secretary, comes out with all these very sweeping, grandiose statements about recovery in the foreword. And then the rest of it is just so much mist and fog. You know, there's nothing there. And Road to Recovery, I'm not sure is quite as bad. It's not much better. No. But there's no action plan. There's no milestones. There's
a set of aspirations or intentions, but nothing to hold people to it or to actually suggest that. So, yeah, sorry, carry on.
I was just going to say, last thing on that is, I think there's a little bit more hope about rights, respect, and recovery. I mean, I'm not there, but whereas the English drug policy situation is just an utter shambles. And it's almost like in England, it doesn't matter. But this is yesterday's news.
Yeah. Listen, I'm really conscious that I've only got you for this amount of time, and you need to get moving shortly, I think.
Yeah, 5 minutes. 5 minutes. We can close up in about 5 minutes. That would be good.
So I'm really interested in, you know, how we get more stuff going, you know, because things that have started up, they tend to start up almost despite the policy agenda or the policy context. And I can think of dozens of examples of this across Scotland and the UK. I mean, what do you think needs to happen? Is there a better way forward? Because what we're looking at right this moment is a reduction in funding for community-based action. There's more going into treatment. There's more going into, you know, kind of even, you know, David McCartney's own, residential rehabilitation, which is needed, absolutely. But I'm on the community side of things, and we're seeing reductions. And the thing that is valued in this is the one-to-one work, the stuff that you talked about before, and practically nothing on what actually connects people and gets them engaged, and you know, and having more of that kind of stuff, more community-based action going.
And one of the things we've managed in England, which I was really pleased about, was when we had our Recovery College event a couple of weeks ago for the College of Lived Experience Recovery Organisations. We got Dame Carol Black there, and for anyone who doesn't know, she's been leading the review of English drug treatment policy. And she is making the right noises about the need for a separate commission and stream in England specifically for recovery organisations. That, you know, one of the problems has always been, and I think especially the Scottish problem, has been it comes from the table of the NHS.
Oh, yeah.
And even to some extent in England, you know, it's been slightly more subtle, but it's often been large organisations like CGL have kind of sub-commissioned little local recovery agencies. And so they've never had sustainability. They've never had, so funding is a massive problem, and continuity of funding, I don't need to tell you this, is a massive challenge. The other problem is the siloed pots, because, you know, the problem of housing money, and well, you know, a good recovery community service has a hub, it has recovery housing, it has pathways to employment and training, it actively engages in communities. And it's that stuff about, like we were saying earlier, the model is still a kind of corporeal individual model of right and wrongs. It's not this notion that if recovery works well, it's about from the individual to the family, to the neighborhood, to the community. That's the ripple effect of benefit. And government and funding doesn't seem to work that way. And so I don't have a solution to the funding question, but you're absolutely right, John. All the best movements have tended to be bottom up, not top down. When they've been top down, and in England especially, you know, there was a pile of money after the 2010 drug strategy, but the leaders, the so-called leaders of the recovery communities in England behaved appallingly, and they basically behaved in their own self-interest at that time. And I moved to Australia in 2011, and I was just astonished looking on at how myopic and self-interested. So, and they blew the confidence people had in, you know, they blew that. And I really hope that, you know, our aims with the College of Lived Experience Recovery Organisations, we've taken a whole year basically to build a kind of radius of trust among the 12 of us, to try and get into a position where we can now engage with people to build. What we're trying to do is build quality standards around for recovery organisations, and to build that sense of an evidence base so that commissioners can't turn around to people and say, well, it's all just wishful thinking on your part. None of this actually happens or makes any difference. So sadly, John, I don't have a quick answer that says you do this and it's all fine. I think there is that thing about, you know, we need to build credible evidence base, but we also need to build credible alliances that are ground up credible alliances.
Yeah. Okay. Listen, this has been brilliant. I just wanted, I couldn't let you go away without talking about the concept of better than well, because I think it's a wonderful thing. If you've never heard it, guys, you're in for a wee treat here. So David, you want to take it away? Yeah.
So look, this really for me started when I had a fabulous medical student when I was in Birmingham called Louise Hibbert, who she wanted to do that. She was doing an intercalating medical degree. So if you do a medical degree, you can do a research 1-year degree in the middle of it. And she did. And she wanted to do it. She just got interested in the stuff about recovery. She had no personal stake, no family background. She was your kind of classic 21-year-old middle-class medical student. And I sent her out to interview 50 people in long-term recovery from alcohol. So 5 years or more using the Betty Ford definition. And we used the World Health Organization quality of life scale. And it measures 4 different things: physical quality of life, psychological, social, and what's called environmental, which is kind of how are you in your neighborhood? How do you fit in? And one of the beauties of using that scale is the WHO published general population norms. So when Louise analysed the data at the end, I kind of looked at it and went, no, you've got it wrong. That can't be right, because the people in recovery are doing better than people who've never had an addiction problem. Go back and do the sums again. But she'd done the sums right. It was me who was wrong. And in 2 areas, social quality of life and how well you fitted into your neighbourhood quality of life, people in long-term recovery were significantly better than people who had never had an addiction problem. And incidentally, subsequently, I did a study of drug and alcohol workers in Australia and the UK who themselves were in long-term recovery. And we found exactly the same thing. Using exactly the same measures, we got the same better than well effect. Now, again, I've already admitted to my magpie tendencies. So the phrase isn't even mine, John, sadly. The phrase comes from Phil Valentine, because around the same time we published the effect for drinkers in Birmingham, he published it for crack users in Connecticut. And essentially, and why does it matter? It matters philosophically for one reason and practically for one reason. The philosophical reason it matters is stop thinking about treatment or recovery support as taking a whole pile of things that are wrong with somebody and wiping them out, because that's not what recovery is. Recovery is a kind of journey to a new place, not back to where people started from. And it's really important that it becomes a growth journey, and a growth journey for the person that ripples out. And all those people who are genuine recovery elders, and I'm pleased to count quite a few of them as friends, they have a kind of serenity, and they have a very modest sense of right and dignity and purpose that you don't find in many people, and it's really important. And then, so that's the philosophical thing. It's not a zero-sum game. It's not like somebody's lost and lost and lost and lost. Let's get them back to that zero starting point. So it's about growth. It's not about, and that's why I think the treatment model is fundamentally flawed, because it keeps trying to do this Herculean task of filling up emptiness, but that's not the right thing to do. And then the second reason is a practical reason why better than well matters, because recovery is a social contagion, and everyone who gets to that point of that kind of recovery, they are the carrier, and again, stolen from William White, they are the carriers of recovery. They are the people who other people observe, copy, learn from, aspire to, admire. And that's how recovery grows in communities. It's the better than well that creates wellness. And, you know, for me, it's just one of those fabulous things. And it just turns in your head everything you think about a kind of traditional medical, clinical model of treating something. Is addiction and recovery is not like ingrown toenails. No, we used it. We used it really effectively in their training for recovery coaching, recovery coaches and stuff. And you could see the look on people's faces when they understood it. You know, and we used a very simple kind of method for teaching it to people. But it's fascinating. David, it has been great talking to you, mate. Well,
honestly.
thank you, John. It's been a pleasure. And I'm sorry for the various confusions and mess ups in our attempts at doing this, but we've got it done. So, look, I better go off, or I'll be reported to educational services in Derbyshire for failing to pick up my son. So it's great to see you, John.
You too, mate.
In touch. Thanks
a lot. Lots of love going forward. All the best.
Thank you. Take care. Bye-bye.
Bye.